Well, to discuss lymphoma and immunotherapy, we have to remember that lymphomas are the tumor of the lymphoid tissue, which represents the backbone of the immune system. Notwithstanding that, for many decades, immunotherapy failed to produce meaningful results in the treatment of malignant lymphomas besides what was achieved by using allogenic bone marrow transplantation, which led to a kind of adoptive immunotherapy, which was curative, at least in some patients with malignant lymphomas. Today, we cure a variable percentage of patients with malignant lymphomas depending on the subtypes, and we are dealing with at least 50 different discrete subtypes of malignant lymphomas. In the past, the treatment has been largely represented by combination chemotherapy. In the last 15 years, we had the first breakthrough as regards immunotherapy by the introduction of monoclonal antibodies, which proved to be active and having important anti-tumor activity even alone in some subtypes like the follicular lymphomas, but which in general, mainly in the most frequent subtype, diffuse large B-cell lymphomas, led to an improvement of the outcome thanks to the combination of rituximab, the monoclonal antibody, with the combination chemotherapy. Now, a lot of new monoclonal antibodies, both naked or combined, generally with immunotoxin, have been developed, and some of them have produced spectacular results, like the anti-CD30 combined monoclonal antibody vedotin-brentuximab, which is able to achieve an 80% response rate in patients with Hodgkin lymphoma, even if they relapse after autologous or allogenic bone marrow transplantation. Well, the new frontier of immunotherapy in malignant lymphoma is represented now by the checkpoint inhibitors. We know that PD-1 is an immune checkpoint receptor which, through interaction with its ligand, can lead to an inactivation of the T cells, which creates an immunotolerance based on which lymphomas might further develop. So, thanks to the development and the discovery of inhibitors, now an important response rate has been achieved, first of all, in Hodgkin lymphoma, but increasingly so also in non-Hodgkin lymphomas. And now many groups are working on trying to combine the checkpoint inhibitors with other forms of immunotherapy or of chemotherapy in order to further optimize their therapeutic possibilities. Another very fascinating possibility is represented by the chimeric antigen receptors carrying T cells, a very complex methodology which has, however, shown spectacular results in relapsing acute lymphoblastic leukemia cases, where this technology and this methodology has become the treatment of choice for patients relapsing after first-line treatment. So overall, this new possibility of immunotherapy are completely changing the field of the treatment of malignant lymphomas, and I have no doubt that at the next Lugano Conference on Malignant Lymphomas of 2017, immunotherapy will represent the most discussed and the most important topic of the conference.